Dear, dear ladies and gentlemen, a very warm welcome to the first webinar of the Mainz European School of Minimally Invasive Thoracic Surgery. This is an official CME activity of the German Society of Thoracic Surgery and is endorsed by several other national societies like the Turkish, the Mexican, the Colombian, the Argentine, and the Brazilian Society of Thoracic Surgery. Before we get started, it's my pleasure to call up Professor Norbert Pfeiffer, CEO and Medical Director of the University Medical Center of Mainz. We are so kind to welcome you on behalf of the university. Professor Pfeiffer, please.
Dear Professor Rösner, ladies and gentlemen, colleagues, it is my pleasure to welcome you here from Mainz for this Mainz European School of Minimally Invasive Thoracic Surgery. I'm quite proud that we have a very, very active department of thoracic surgery that encounters and supplies minimally invasive methods, endoscopic methods, but also robotic methods. And I understand that this series is meant to talk about the latest achievements in thoracic surgery and also give a venue to discuss these methods and establish their value. And I'm also quite impressed by the panel of speakers, for example, from the United Kingdom, from Germany, from Hong Kong, from many parts of the world, and also for the audience that is comprised of many distinguished colleagues from all over the world. So I wish you a very successful series of CME credited events that you hold together, 11 events between now and next March. And I think this is a very important series of lectures and encounters that you will have now. Now, dear Professor Rösner, thank you very much for organizing this, for setting this up, this Mainz European School of Minimally Invasive Thoracic Surgery. And a warm welcome to you from wherever you are to listen and attend the school here in Mainz. So all the best for today and for the whole series. Thank you very much for your attention.
Well, thank you, Professor Pfeiffer. That was very kind of you to come here and to welcome us all. So I think we need to start now, and I think I don't really need to introduce Tim Batchelor, but I do. He's a consultant thoracic surgeon from Bristol in the UK. He will be our first speaker today. And Tim is the first author of the European ERAS guidelines and is one of the worldwide key opinion leaders when it comes to thoracic ERAS. As panelists, I would like to welcome and introduce Jens Neudecker from the Charité Hospital in Berlin and Patrick Zardo from the MHH in Hannover. Both are deeply involved with ERAS in Germany. For later on, when Tim has finished his presentation, we will have the possibility of a discussion. And I would suggest that you use the FAQ button, which you find down below, for posting your questions. Or if you want to speak up, you can raise your hands by pushing the raise your hand button. All right, let's get started. Tim, it's my pleasure. Go ahead, the stage is yours.
Thank you. I will just share my screen and then we'll get going. So hopefully you can see that. So thank you, Eric, and thank you to the committee for inviting me to talk today. It's my great pleasure. And we're really going to divide the talk into, well, three sections really: an introduction to ERAS, and then the evidence for ERAS. And then intertwined within that is the evidence for VATS, and in particular, I'll present the Violet study. These are my disclosures. So ERAS, what is it? It's enhanced recovery after thoracic surgery. But before I talk about this, I'm going to talk about this incredible man. This is Eliud Kipchoge, and some of you may have seen him run a couple of years ago when he was the first man to run under 2 hours for a marathon. So it's one of the great sporting achievements of our time, I think. And how did he achieve this? Well, it was actually multiple interventions were put in place to try and optimize his running time. So yes, he had a flat course. Remember, in Austria, there was a line on the road, an optimal running line. There was a laser pointer which showed him the pace that he should be running it at. You can see here he was running in formation with a group of other elite athletes, and running in a V formation, which was supposed to be aerodynamic. The weather was perfect, and of course he'd got all the right kit and the training and the nutrition and what have you. So multiple interventions to try and create the best possible running time. But in amongst all of that was something else, and this is what he was wearing on his feet. This was the Nike Vaporfly. This is a great advance in running shoes, and it said that for an average marathon runner who can run a marathon in 3 hours, this will knock 6 minutes off your time. So this was one of the outstanding interventions, the running shoe, amongst all the other little interventions. And I talk about this because the philosophy in achieving this greater feat in the marathon is pretty much the same philosophy that we're trying to apply to perioperative care to improve patient outcomes. So if we take our average patient who's coming in, here they are at home. This is their level of functioning on the y-axis and time on the x-axis. They come in, they have their lobectomy operation, and this is harmful. We harm the patient. And so their level of functioning declines. And then after their surgery, they spend some time in hospital getting better until they reach a point, what we call the point of minimal level of functioning. Once they reach that point, they're about ready to go home, and they will slowly recover at home as well. Now, if we think about all the things which impact on their level of functioning, for our average lung cancer patients, we've got COPD and their fitness and how much lung you're taking away and their BMI. So all of these will have an impact on how far they will deteriorate. And then when they're trying to get better afterwards, there are a number of other factors which are going to impact on their recovery, including pain and nausea, their nutritional status, whether they're smokers or not, whether they're immobile in bed or walking, the number of tubes you've placed, and also their fluid status. And the worry is that if they do not achieve this minimal level of functional recovery, then they'll develop complications or a longer length of stay, or there'll be a burden on their family, or they may attend healthcare more often, or an inability to work. So it's incumbent on us really to try and improve the patient's lot here. And this is where ERAS comes in. So what is ERAS? Many of you are familiar with it, how it's divided into 4 phases. So essentially, we're looking at the entire patient pathway rather than just trying to improve the operation itself. We're looking at the preoperative phase, the admission phase, the operative phase, and the postoperative phase. And we're trying to, within each phase, remove any dogmatic practice, add in evidence-based interventions. We're using the aggregation of marginal gains in the same way that the marathon runners do to try and improve their performance. We standardize care, and of course we involve the whole multidisciplinary team. And it's important to say that the goal of ERAS is the quality of recovery, and we do that by reducing the stress response to surgery. So, as I've already said, we focus on the entire patient pathway. There's a number of evidence-based interventions, which we'll talk a bit about. And we eliminate some of these care elements that are unnecessary, dogmatic, or quite frankly, delay a patient's recovery. The end result being less complications and a quicker return to normal function. Now, reduced costs and a shorter length of stay are a byproduct of this process and not the primary goal of an enhanced recovery pathway, which is why we don't call it fast-track surgery anymore. There is a physiological basis to all of this. If you do an operation on someone, you harm them and you trigger a pneumohumoral response. So the sympathetic nervous system is activated, a whole bunch of cytokines are released, And that results in a number of processes around the body, including whole body protein catabolism, gluconeogenesis, and insulin resistance, which results in hyperglycemia. And these things are all harmful. Catabolism results in a loss of protein and cellular dysfunction, whereas insulin resistance impairs cellular function during injury to the tissue. So not good things you want if you're trying to recover from an operation. And so there are some elements of ERAS which can blunt this response, this inflammatory response. If we look at the pre-op nutritional status, we can improve the lot of the malnourished patients. Carbohydrate loading can minimize insulin resistance. Regional analgesia can reduce the endocrine stress response. Anti-inflammatory drugs can reduce the endocrine stress response as well. Early feeding secures an energy intake, and then optimal pain control reduces the endocrine stress response, as well as reducing insulin resistance. And at the same time, we're trying to maintain euvolemia, and this itself prevents organ dysfunction by maintaining cardiac output and maintaining oxygen delivery, and preventing fluid overload and all the consequences of fluid overload. So I'm sorry, that's quite complicated. That's the science behind enhanced recovery. But if we go back to that patient pathway, that level of functioning, here's our patient again, but here on the blue line, this is what we're trying to achieve. We're trying to improve their fitness. We're trying to minimize the impact of the surgery, and then we're trying to accelerate their recovery afterwards. And up until 2019, it was practiced in a whole load of specialties, principally in colorectal, orthopedics, urology, and gynecology. But as Eric said, we introduced the guidelines for thoracic surgery. They've been downloaded now around 75,000 times. But for those of you who will have read them, they're quite large, aren't they? They're quite daunting. In fact, there are 21 sections with 45 separate recommendations. I'm not going to go through the elements individually, but here's just a snapshot of what you might see in the 4 different phases of the patient pathway. So there's quite a lot that we've looked at, that we've tried to improve each component of the patient pathway. And so while the guidelines have been broadly accepted, they have been criticized as well, not least by René Peterson, who is one of the authors of the guidelines, and Henrik Kellett, who is the grandfather of enhanced recovery. And in an opinion piece a few months ago, they wrote, "It is difficult for the busy clinician to interpret the many different ERAS factors to be considered for improved implementation." And at the same time, they said, maybe we should just concentrate on the key components for early recovery. So in other words, are there some elements which are more important than others? So their criticisms were threefold, really. There are too many recommendations. Yes, there possibly are. Some evidence is just transferred from other specialties. Yes, that's true, but in a lot of ways, thoracic surgery is not that much different from colorectal surgery or gynecological surgery. And they say that some items are already standard of care, and that is true, but I've visited quite a few centres in Europe, and I have seen that what I think is standard of care is not standard of care throughout the world. And so that is why some elements are included in the guidelines. They conclude by saying that a median length of stay of less than 4 days is common practice in many units where minimally invasive lung surgery is the standard of care. Now, it is in Copenhagen, in their bubble in Copenhagen, but around the world that is just not true. And so if we look at some of the practice elsewhere, so this is in England, this is the latest data we have for England for all units. And here we've got a median length of stay for lung cancer surgery. So the top 5 units in the UK, of which Bristol is one, has a median length of stay of 4 days and a VATS rate of 70%, with a very high readmission rate, by the way, but this is true throughout. The median length of stay overall is 5 days, and that's seen in 40 units, again with a high VATS rate. And then there's another 5 units with a length of stay of 6 days, again with a high VATS rate. And then there's some straggling units with a length of stay of 7 days and quite a low VATS rate. Now you can ask, why is there such a difference? Why is there a 50% difference between the best performing units and the rest? And the only conclusion that you can really make is that there's a difference in perioperative care. And that indeed is what's seen in the Netherlands. So this is a nice piece of work from all thoracic units in the Netherlands, looking at mean length of stay. The mean length of stay in the Netherlands is 7 days, and it's not related to the size of the thoracic unit. And what Eric von Meyenfeld and colleagues concluded was that actually the large variation in length of stay that's seen after a VATS lung resection is due to variations in perioperative care routines. So pretty much the same conclusions that we've made in the UK. So that's fine. We have the guidelines for ERAS, but are they just guidelines that have been produced in a vacuum, or is there now evidence for their efficacy? This was one of the first papers to be produced on ERAS and thoracic surgery. It comes from the United States, from Texas, and they looked at enhanced recovery after thoracotomy for lung cancer. And what they showed was that after a period of time, they managed to reduce their length of stay from 5 days to 4 days. So that's quite impressive for a thoracotomy lobectomy. But they also managed to reduce their pulmonary complications and their cardiac complications. So this predated the guidelines, and so there are some elements which can be improved again. This is Johannes Kratz and his team from San Francisco. And they actually implemented the ERAS Society guidelines. And what they showed was a reduced length of stay, fewer postoperative complications, lower opioid consumption, lower costs, and no change in readmission rate. And in fact, this was the first external validation of the ERAS Society guidelines. So we're really pleased when they published these results. But just in the last month or so, we've got some more robust data rather than single series data. This is a systematic review which has just come out a few weeks ago in JTCVS Open. And the authors looked at all units which had published their results on enhanced recovery after lung cancer surgery. So there's quite a few here. And they looked at a number of things. Here in this graph, they've looked at length of stay, and there was a reduction in length of stay favoring ERAS. And overall, they included 19 studies with 8,500 patients. And they showed that actually there was a reduction in length of stay of 3 days if you introduced ERAS into your lung cancer surgery program. They also noted a decrease in postoperative complications, and there was possibly a decrease in the readmission rates, although this isn't something which has broadly been seen. Now, they did recommend that randomized controlled trials should be performed, so we can talk about that later if you like, about how difficult that might be. So another systematic review and meta-analysis has also just been published, this time in the Journal of Thoracic Disease. And again, they come to broadly similar conclusions, maybe not surprising as they've analysed the same papers, more or less. So again, postoperative complications are reduced in favour of ERAS. Readmissions, they didn't think that there was a reduction, but length of stay was definitely reduced in the ERAS group. So 2 systematic reviews just published in the last month or two, which seem to confirm the benefits of ERAS in thoracic surgery. Now, we looked at our series a few years ago, and this is from about 400 lung cancer patients. And what we were interested in was how compliant patients were and how their compliance would affect outcomes. And what we found was that the more compliant you were with the ERAS protocol, then the less likely you were to have a post-operative complication. And similarly, the more compliant you were with the ERAS pathway, the less likely you were to have a delayed discharge. In other words, your length of stay was less. The group in Lausanne in Switzerland, Michelle Gonzalez's group, also did a similar piece of work, which was published last year, looking at their 192 anatomical lung resections. And they divided their patients into two groups, and they were pretty much half and half. So they had what they called their low ERAS compliance group. So those patients who did not achieve 75% of ERAS elements in the pathway, and their high compliance group who did achieve 75% or more. So as I said, around half of their patients were in the low compliance group and half in the high compliance group. And what they noticed was, not surprisingly, there were fewer complications if you were highly compliant with an ERAS pathway, and also there was a lower rate of delayed discharge if you were highly compliant. So in other words, you went home sooner. But that's not the whole message, because if you look at both of those papers, there are a few individual elements of patient care that appear to be more important than others. So yes, compliance with the whole pathway is important, but there are a small number of elements which seem to be more important than others. And this harks back to the paper, that opinion piece by Peterson, saying that they thought that some elements were more important than others. And what we found is that carbohydrate loading a couple of hours before surgery is important, as is early mobilization, as is early removal of chest tubes, as is early cessation of opioids. And these two are actually inextricably linked, because chest tubes are one of the major causes of post-operative pain, certainly after VATS. But here in the context of this talk, VATS was an independent factor in the ERAS pathway. So let's just quickly talk about these then. Carbohydrate loading, here is a commercial preparation. This is the one that we use and we give to patients 2 hours before surgery, 400 mils of a complex carbohydrate drink, or you can just go to your local supermarket and get something off the shelf. And what does carbohydrate loading achieve? Improves for hydration, it improves patient well-being. We saw at the beginning that it reduces insulin resistance. It also reduces post-operative nausea and vomiting. There's no direct evidence in thoracic surgery at the moment. This is extrapolated from colorectal surgery, but I understand that some groups are looking into this. So what about early mobilization? We keep going on about early mobilization because it is an intuitive component of enhanced recovery. There are well-described deleterious effects of immobility. So if you just lie in bed after your surgery, you're more likely to get post-operative complications. You're more likely to have a venous thromboembolism, and you're more likely to become physically deconditioned with loss of your muscle mass. But there have been a number of trials looking into this, prospective trials, and actually it showed that a systematic review showed that there was no benefit, but that was probably because the studies were of very poor quality and the results were conflicting. And of course, if we look at the ERAS papers produced already, we've shown that early mobilization is an independent predictor of outcomes. But a few people have looked at mobilization. This is a group from Virginia. You don't need to look at this pathway, but essentially they focused on mobilization. So the elements in red are mobilization. So mobilizing before surgery, mobilizing on the day of surgery. So walking within an hour of surgery, and then walking back to the ward rather than going in a chair or a trolley. and then walking many times once you get back to your room. So here's a patient instruction board in a room, and you can see it just says walk, walk, walk. They had a very low median length of stay after VATS lobectomy, 1 day, really quite remarkable. This is not necessarily a paper about thoracic surgery. It's about many forms of major cancer surgery, but it was quite novel in that the investigators looked at your smartphone. So this is my iPhone. If you look on the health app, it tells me how far I've walked each day, how many steps I've done. And what they wanted to know is activity related to post-operative recovery or vice versa. And so they divided these patients into those that had not had a post-operative complication and those that had, and they found that compared to baseline, a patient's activity stayed much the same after surgery if there was no complication, whereas those with complications had a much reduced mobility after surgery. It's difficult to know what comes first. Does the lack of mobility cause the post-operative event, or does the post-operative event cause the lack of mobility? And that's something that will be looked into further. But this, I think, is interesting. This is something that Henrik Kellett has been interested in for quite a long time. And this is actually from Kellett's group in Copenhagen, along with René Peterson. And they attached accelerometers to patients immediately after their VATS lobectomy, and then measured their FEV1 and their oxygen saturations in either a supine, a sitting, or a standing position at different time points after surgery. So this is 6 hours after surgery on day 1 and on day 2. And what they found was that as you went from supine to sitting to standing, both your FEV1 increased, as did your SATs, so as your oxygen saturation, suggesting that early mobility improves your function. So there we go. Chest drains, why do we bother? Because they're sore. We know that early drain removal reduces drain pain and improves respiratory function. You can have a protocol-driven chest drain service with just one drain, no suction, digital drainage systems, and a high threshold for pleural fluid output. So it doesn't matter if 500 mils a day are coming out of the drain, it should be possible to remove that, and that is evidence-based. So that's drains. And what about pain relief and opioids? This is from Linda Martin's group, also in Virginia. This paper has been cited many times. What did they learn from introducing their ERAS pathway? Well, this was morphine use. What they demonstrated in the VATS group was that there was a massive reduction in opioid use after the introduction of ERAS. So this is in VATS, and the same was true in thoracotomies as well. So ERAS resulted in a big reduction in opioids. This has been confirmed by the group from Miami, who have looked at both their robotic lung cancer surgeries as well as their thoracotomies. These graphs show pain scores. The blue line is before ERAS, the red line after ERAS. So reduce pain with an ERAS pathway in both the VATS and the thoracotomy group. But I think more important than that, this is morphine use. So in hospital, in the ERAS group here in red, significant reduction in morphine use in the VATS group, but not in the thoracotomy group. But after discharge, big reductions in opioid use. And this has massive implications for the opioid epidemic in North America, but also in Europe. But also there's emerging evidence that opioid use perioperatively reduces lung cancer survival. And so that's another important facet of ERAS. Okay, so what about VATS then? Because this is a series of lectures about minimally invasive surgery. And what is the evidence for VATS? It's an important component of ERAS. We've shown that. Well, let's quickly look at post-thoracotomy pain. Why is it sore when you operate on people? Well, this is a thoracotomy. You can get fractured ribs and peripheral nerve damage, but the main source of pain is intercostal nerve damage. This is the most painful incision that you can perform on a patient. What is the second most painful incision on the body? It's VATS. It's not any other part of the body, it's VATS. But VATS and VATS lobectomy has been around for a long time. I trained in Edinburgh originally with Bill Walker, who did his first VATS case in 1992. And over the years, a number of papers from expert centers were published. This is a meta-analysis from Jan, published around 10 years ago. And they said, look, VATS is associated with less pain, with better shoulder function, with earlier mobilization, with shorter length of stay, better preservation of lung function, and better quality of life. And another meta-analysis suggested that VATS was associated with improved 5-year survival. So this looks fantastic, doesn't it? But there are problems with all of these VATS lobectomy studies. There's massive selection bias. There's reporting bias as well. These studies are usually coming out of university hospitals with top performing surgeons. The voluntary national databases often have poor quality data if you're trying to extract that. And any propensity matching which is used in these comparative studies is going to be poor if the data that you're putting in is poor in the first place. And what we've often seen is that the post-operative care of a VATS patient is different from a normal patient anyway. They often just have one chest tube, no epidural, much more aggressive drain management, and so on and so forth. So it's not fair to compare these case series of VATS with our historical controls of thoracotomy. So you need a randomized controlled trial, and we are now lucky enough to have 2 large randomized controlled trials. There's the Ben-Dixon study from 2016, and then the Violet study, and I'll talk about both of those. So the Ben-Dixon study is from Odense in Denmark, 203 patients randomized with stage 1 lung cancer, randomized 1-to-1 to having a lobectomy via an anterolateral thoracotomy or a lobectomy via VATS. And the bottom line was there was less clinically relevant pain in the VATS group and a better quality of life up to 1 year. Now, when you dive into the data in a little bit more detail, then the results aren't quite so compelling. This is, they've had to manipulate the pain measurements. So this outcome is patients with moderate to severe post-operative pain. In the VATS group in the light shade here, and the thoracotomy group in the dark shade. And so, yes, in hospital, there was quite a big difference in pain between the 2 groups. And then it was sustained over the course of the study period, but the numbers of people with significant pain was really quite small. So it's difficult to know what to make of that. Similarly, this is quality of life. They just use the EQ5D instrument, which is quite a simple instrument to use. And yes, there was a better quality of life at 1 year in the VATS group, but again, quite small numbers. So the Violet study then is 503 patients, or was 503 patients, a more liberal inclusion criteria, so stage 1 to 3 and 0 to 1 non-small cell lung cancer, randomized 1-to-1 into thoracotomy or VATS lobectomy. The initial results were presented in 2019 at World Lung, and they were just the in-hospital results. And what was shown was that pain, there was actually little difference. Complications were less in the VATS group. This is in-hospital complications, 32 versus 44%. Length of stay was less in the VATS group, 4 days versus 5 days, and nodal upstaging, no difference. So they were equivalent oncological operations. Now, I'm just going to show to you now what Eric Lim presented at ASCO a couple of months ago, which is the final results from Violet. These are Eric's slides. This was the primary outcome measure. So a measure of clinical efficacy, the primary outcome measure was quality of life at 5 weeks post-surgery using the EORTC instrument. And there was a significant improvement in quality of life in favor of VATS. Here we have the timelines, 2 weeks, 5 weeks. So this is the primary outcome measure here. But this improvement was sustained. And you can see that in the VATS group, they seem to return to normal by, or certainly achieved a steady state. They never returned to normal, but they achieved a steady state by about 3 months, whereas it took the VATS group 6 months to achieve their steady state. What about in-hospital pain? We've already shown that this is the VATS group in red. There was reduced pain at day 2. What about pain to 1 year? Maybe more importantly, here's the take-home message here. VATS results in less pain than thoracotomy up to a year after surgery. And here we have the timeline. We can see that VATS seems to be more efficacious early on in the patient pathway, but this improvement is sustained out to 1 year. What about adverse events and readmissions? There were less adverse events in the VATS group, but the significant adverse events were the same between the two groups. So anyway, less complications between in the VATS group. Readmission rates, there was no difference between the two groups. What about the oncological quality? Because the critics of VATS have always said it's not as good a cancer operation. And so we looked at a number of metrics. The number of lymph nodes harvested was the lymph node stations was the same in both groups. The R0 resection rate was the same. The upstaging from N0 to N1 or N1 to N2 was the same in both groups. So they appear to be equivalent oncological operations in terms of quality metrics. In terms of uptake of adjuvant treatment post-op, it was the same in both the open and the VATS group. So this sort of goes against what has been published previously, where VATS was supposed to confer a benefit. And long-term survival up to 1 year is the same in both groups. What about quality of life? We've already looked at the overall quality of life marker. So this is sort of global quality of life, but role functioning, another marker of quality of life, is better in the VATS group, as is social functioning as well. And then finally, we'll look at economic outcomes. This is the VATS group, this is the open group, this is the total cost over 1 year. And in the VATS group, it's around £11,000. In the open group, it's around £14,000. And a large part of that is both intensive care and high dependency stay, but also healthcare costs after discharge in the first year after discharge. So these are visits to ED, readmissions, and visits to your family practitioner. So that's it. What can we say in summary? Well, ERAS then appears to improve surgical outcomes and is associated with a reduced post-operative length of stay. Increase in compliance with an ERAS pathway is associated with better patient outcomes. Some ERAS elements appear to be more important than others, including the use of VATS. And what can we say about VATS then, as VATS is an important component of ERAS? From Violet and from the Ben-Dixon study, VATS lobectomy is associated with less pain. It has fewer complications and a shorter length of stay than thoracotomy, and that is achieved without compromising oncological outcomes. The superior recovery that we see in hospital continues after discharge, with improved physical function and other measures of quality of life up to 1 year. There are less complications and possibly readmissions, and that continues all the way up to 1 year. and VATS lobectomy is associated with lower overall costs up to 1 year. So if we're going to say anything about enhanced recovery, then I think this paper sums it up nicely. There's nothing special about enhanced recovery. What is it? Enhanced recovery after lung resection surgery is knowing what we can do and doing it. Thank you very much.
Yeah, Tim, thank you very much. Fantastic overview, as expected, actually. I heard you a couple of times before, and you're always a fantastic speaker. I have so many questions for you, but I hold myself back a little bit and open the discussion actually to the floor and to the panelists. So please, Patrick and Jens, I guess you have many questions as well.
Yeah, yes. Tim, thank you for your excellent talk. It's truly compelling. You made an excellent point, and this certainly have to encourage everybody to get an ERAS program started over at their own hospital. What are the key points to getting everybody involved in the first place, to get a program started in the very first place?
That's an excellent question, because that is often where things fall down, isn't it? The most important thing that is that you have buy-in from the whole team. And by the whole team, I don't just mean you as a surgeon and your junior and your anesthesiologist. I mean your preoperative nursing staff, your operating room staff, the ward staff, the physiotherapists, the nutritionists, the pharmacists, everyone. And so you need to convene as a group. You need to know what your goals are. And your goal is ultimately to improve patient outcomes. You need to have a look at what you're doing at the moment and compare that to best practice. And the shortcut to that is to look at the ERAS Society guidelines. Not everything that you can do, you won't be able to do everything, but you can certainly introduce some things, including the more important things that we've talked about today. And it's important to have management on your side as well. So it's quite an easy sell to management. You can talk about reduced length of stay and reduced costs. As we said before, that's a byproduct. What you're trying to do is improve patient outcomes.
Fantastic talk. Thank you very much for this presentation. We have a question from the audience, and it's a question from Trufa Dennis. How could you explain the high rate of readmission, 30% after VATS?
Yes, well, okay, so this was the, let me see what that number is. So there's in the Violet study, the complication rate after VATS was 30%. I don't know if that's what he's referring to. The readmission rate in the UK is 40% after all lung cancer surgery. And that appears on the face of it to be really high, particularly when you look at what's published in the world literature. The English NHS is almost unique in that it has a very robust data collection system. And so I might operate on a patient and they might live 100 kilometers away. I don't know if they're being readmitted to their local hospital or not, but the NHS will pick that up in the data that it presents to us later on down the line. So I think as surgeons, we don't realize just how many patients are readmitted to surgery. The data is slightly dirty as well, though, because some patients are readmitted because they have a broken leg or cholecystitis or a complication after their adjuvant chemotherapy or something completely unrelated. But for sure, and I'm sure you've seen it, Jens, a patient of yours will attend an emergency department in another hospital with some post-operative pain, and they're assumed to have a pulmonary embolism or something else, and they're admitted and what have you. So there's a lot of education that needs going on there. In terms of the complications after surgery, again, I was surprised when I saw that VATS had a 30% complication rate and thoracotomy had a 40% complication rate. But again, that's real life. This was a pragmatic randomized controlled trial, and we picked everything up because we had a very good team of data analysts and research nurses. And so I think it's quite different from the papers that we see published in the world literature, where someone might only have a 10% or 15% pulmonary complication rate. That's not real life. So that's my explanation of what's going on there.
Okay, we have another question from the audience. I think this colleague can talk right now.
You got the video permission running? The person from the audience?
Probably not.
Sharifei, you can unmute now if you want.
Okay, probably we wait for other questions, but I would like to ask you, Tim, regarding, you mentioned in your talks that some ERAS elements are more important than others. And for example, we talk about early mobilization. Can you hear me, actually? Yeah. And early mobilization is not well defined in the guidelines. And I don't know exactly whether you have a special plan, a schedule for your patients in daily clinical routine, what the patients should doing for early mobilization.
Yes, you're right, Jens. It's not defined, and I don't think anyone has defined it. So it's done on an individual hospital basis. We have a patient's diary. So this is a pamphlet that the patient is expected to read before they come into hospital and then fill out whilst they're in hospital. On the first day, we expect them to be sat out of bed for 8 hours, and that can be in 4 lots of 2 hours. We expect them to walk 50 meters 4 times as well on the first day, and then that increases each day. Now, that's actually quite a conservative objective, and I would rather that it was mobilized 10 times, or actually what I'd really like to do is attach pedometers to patients and actually get them to count the number of steps they're walking and have some sort of positive feedback that way. Now, if we look at some of the more aggressive departments around the world, Salamanca in Spain, for example, or that unit in Virginia in the USA that I demonstrated as well, we now have some thoracic units which are asking their patients to walk from the post-anesthetic care unit back to the ward, and they're expecting them to walk many meters each day. And I think that should be the objective.
Would you recommend to mobilize the patient directly after the operation?
Yes, absolutely. And within our hospital, we are coming up against some barriers with particularly in our post-operative care unit. And also we don't have enough staff, I don't think, to supervise. But ideally, we would want to mirror what has gone on in Virginia, in the USA, where patients mobilize within 1 hour after surgery. We certainly know one of the leading hospitals in England for colorectal surgery is Guildford in southern England, and they certainly mobilize their anterior resection patients, so their colorectal cancer resection patients, within an hour of surgery. So it is achievable. There are many barriers to that, but they can all be overcome.
Yeah.
Okay, we have some further questions from the auditorium. People would like to know your opinion on tubeless lobectomy.
Yeah. Okay. So that's absolutely fine. So one of the great things about tubeless lobectomy is that it's pushing the boundaries, isn't it? It's which we should all be doing to a certain extent, but at the same time, we need to be keeping our patients safe. So it's how far can we go? So a great example of this is Henrik Kellett, actually, in Copenhagen, when he first introduced what he called fast-track surgery at that time, when he pushed and pushed and pushed with his colorectal cancer patients, and he was managing to get them home on day 2 after surgery, which was unheard of in the 1990s. But then he noticed that there was an increase in complications and an increase in readmission rate. So he realized that he had pushed the boundaries too far and came back a little bit. Now, with tubeless lobectomy, is that another example of pushing the boundaries too far, or is it actually something that is achievable? People said the same thing about VATS when we brought that in 25, 30 years ago as well. So tubeless, there are 2 things that tubeless means, isn't it? One is non-intubated, and certainly you can do non-intubated intermediate procedures like wedge resection and lung biopsy and pneumothorax surgery and what have you, in a very straightforward and a very safe way. Is it safe for lobectomy? Possibly, but we need more data. And what about removing a chest tube on the day of surgery? We can certainly do that for more minor lung surgeries and mediastinal surgery. Can we do it after lobectomy? Possibly, but I think a lot of people would feel very unhappy about that, because of the consequences of not having a chest tube in and a pneumothorax or a bleed in particular. So I don't know is the answer. For sure, chest tubes are the source of great pain, and so we should be removing them early. Should we be removing them in the operating room? I don't know, possibly. There's certainly a randomized controlled trials going on looking at using tubeless surgery for more minor surgery. At the end of the day, you have to ask, what are you trying to achieve? Does not ventilating a patient affect their outcomes? Again, possibly, because you do get inflammation in both the non-ventilated lung and the ventilated lung during one lung ventilation. So it might reduce the inflammatory response to surgery. Does having no chest tubes in affect patient outcomes? Probably, because you're likely to have less pain. But is it safe? I don't know. And I don't think anyone truly knows yet.
All right, Tim, I have a question as well. It's more of a practical one. You nicely demonstrated what a good effect carbohydrate load has when you deliver it like 2 hours before surgery. We tend to bring in the patient on the day of surgery. So
yeah,
they come in the morning, 15 minutes later, they're in the anesthesia unit getting induction of their anesthesia. So how do you make sure that it's 2 hours before? Do you send them home when you see them first with a bottle of Gatorade or whatever, or do you tell them to buy it, or how do you do it?
Yeah, no, that's
how many complications do you have with that? Because they forgot that they drink 5 minutes before they enter the hospital.
Yeah. So yes, you're right, Eric. That's exactly what we do. So the patients are sent home with the preoperative drinks. They are told when they wake up in the morning to take them at 6 a.m. instead of their breakfast, and then they travel into the hospital, and the working day starts at 8 a.m. And then if the patient is not first on the operating list, if they're second, and so might go down at say 11 o'clock or 12 o'clock, then they will be allowed to drink water up until 2 hours before surgery, and then they have carbohydrate loading again before they come down. 2 hours before. The 2 hours is a safety margin, if you like, because if you were to have 400 mils of a complex carbohydrate drink, it would probably safe to induce anesthesia in you around 45 minutes after that. The water and complex carbohydrates are cleared very, very quickly from the stomach.
And another question, this is more about the length of stay, actually. How valid is the data from different countries? Because when I look at the US, they tend to discharge the patient to the hotel across the street of the hospital. And when I remember back my time in the UK when I was working in London, they had length of stays in the Brompton like 3 days, but patients were sent to their referring hospital.
Yeah,
they counted at 3 days in the Brompton. So, how fair is the comparison between different countries, and is that a really valid data set?
Yeah, so there are some countries which have extremely robust data collection independent of their thoracic surgical unit. So the Netherlands is one, and places like Denmark and England as well, not necessarily the whole of the United Kingdom, but England in particular. So your patients at the Brompton, even though they're sent to another hospital, that will be picked up in what we call the hospital episode statistics, which are a global, it is part of a global data collecting exercise within England. So I think we can be fairly confident about the England's results. The US, I agree, it's biased for a number of reasons. Yes, they might get sent to a hotel. We also, in the STS database, they don't collect data from half the people who have thoracic surgery in the USA, because of course half the people in the USA have their treatment done by general surgeons in non-specialist hospitals, and that data is just not collected. Yes, so you're right. It's not always possible to compare one country with another. And of course, whilst we're on there, you're sitting in Mainz in Germany, and there are different levers and inducements for getting people home in time as well, depending on the healthcare system that they're working in. But I think it's important that we don't focus on length of stay. As I said earlier, length of stay is a byproduct of the process and is not the primary aim of the process. The aim of the process is to reduce the inflammatory response of surgery and improve patient outcomes as a result of that.
I totally agree. I have one last question, and this is in regards to the PVB, to the Peripheral Catheter. We use them a lot, even in small and minor, like VATS resection cases, and we think it's very beneficial for the patient. Most of the patients we're doing by VATS, lobectomy, small procedures, they don't need any opioids at all. But the only downside to this, that's another cable coming out of the patient, and mobilizing is restricted with that, because now you have two cables, the chest drain with the medulla pump on the end, and maybe a big syringe pump system for the PVB. Do you have any good suggestion how we can cope that problem?
Yep, so we're in the same position as you. So we still use paravertebral catheters for our major lung resections, both VATS and open. We don't use epidurals at all. No one should be using an epidural, really, unless it's a massive chest wall resection. I don't think. There are far too many side effects, and the pain relief is equivalent. We have our paravertebral catheter attached to an elastomeric ball, which is then the patients can just attach it to a lanyard and hold it around their neck. But you're right, it's still another tube. Other centers have moved away from catheters altogether. So no wound catheter, no paravertebral, no erector spinae, no serratus anterior block. Just using intercostal blocks at the time of surgery. And so that's an interesting thing to explore. As you may know, in North America, there is a preparation called liposomal bupivacaine, which is a slow release bupivacaine. It takes 72 to 96 hours for all the bupivacaine to be released. And so if you use that as intercostal blocks, then there's some suggestion that you get long-lasting pain relief. It's not licensed at the moment in Europe, but hopefully it will be at some point. But I think, yeah, you're right. We'd like to move away from catheters altogether. It's something that you've just got to try. Yeah, I think you need to try it and see if it works. But I think one of the things that you said in your question was vital and about opioids. We're trying to reduce opioids or eliminate opioids because of the side effects, which will keep a patient in hospital, but also the emerging evidence now around cancer survival as well.
All right, thank you. So, answer any other questions from the floor? Maybe Jens, Patrick?
Of course, I have a last question regarding prehabilitation, Tim. Prehabilitation always is a hot topic in the context of ERAS. And the question is, should you implement a prehab concept without an ERAS concept, or is it only possible to implement a prehab concept within an ERAS program?
So ideally, it should be within an ERAS program, but it doesn't have to be. It is just one component of an ERAS program. If you, again, what are you trying to achieve with prehabilitation? You're trying to get the patient in the best possible state to withstand the surgery that is about to be, that they're about to endure. So if you can improve their muscle mass, their fitness, their nutrition, their smoking status by a prehabilitation program, then that's something. If they're then part of an ERAS program after that, then that is ideal. I think that's the bottom line. I think you'd agree with that, Jens.
But should we categorize patient for a prehab program?
Should we what? Sorry.
Categorize? Should we differentiate?
Oh, I see. So some patients have ERAS and some patients should not have ERAS. Is that what you mean?
No, prehab.
Oh, I see. Sorry, prehab. Okay, so what limited evidence there is so far suggests that those patients who are least fit have the most to gain from prehabilitation. So there are some studies which have just looked at those patients who are unfit and normally measured by VO2 max, and normally with a VO2 max of less than 15 mils per kilo per minute. The Birmingham group in the UK looked at everyone and were unable to show a significant difference in outcomes with prehabilitation, but that's because they included people like you and me having lung cancer surgery, as well as the 80-year-old smoker with a BMI of 15 who hasn't left the house for 3 months. So if you are to develop a prehab program, then you target the unfit patients first.
Maybe just a super short question. I really like your Kipchoge slides. So what's your equivalent of what's it called? The Nike Air Zoom Alpha Fly. If you had to choose just one item, which one would it be?
Oh, God, you got me. Okay, can I? It's probably VATS. It's probably VATS, isn't it? But it's a toss-up between VATS, aggressive chest strain management, and early mobilization. I think those are the three.
Okay.
All right. I think that was the perfect closing remark from you, Tim. Once again, thank you very much. It was a pleasure listening to you, and it was a pleasure following the discussion from Patrick and Jens and the audience. I think we are in time. We should close now. I invite you all to come back on the 20th of October for the first VATS lecture, upper lobe resections, official last VATS resections presented by Silvio Buderi from the Royal Brompton Hospital. Thank you very much. Thank you, Tim. Thank you, Jens. Thank you, Patrick. And see you all back soon. Bye-bye.
Thank you.
Bye-bye.
Bye, guys.